Hello and welcome to the Ross University School of Medicine Procedural Skills Arterial Blood Gas Lecture Presentation. I am Dr. Eric Patten and I will be guiding you through the lecture today. The learning objectives for this lecture will be as follows. Identify indications and contraindications for performing an ABG. Site selection. Modified Allen test. Challenges in performing an ABG. Tools and materials required to perform an ABG, performing the procedure, post-procedural care, complications with performing ABGs, and acid-base analysis. What does an ABG measure? Oxygen tension, carbon dioxide tension, acidity of the blood, oxyhemoglobin saturation, bicarbonate concentration in the arterial blood. Some also measure the methemoglobin, carboxyhemoglobin, and hemoglobin levels. Indications for performing an ABG. Identification and monitoring of acid-base disturbances, measurement of the partial pressure of oxygen and carbon dioxide, assessment of the response to therapeutic interventions, such as insulin in patients with diabetic ketoacidosis, detection and quantification of the levels of abnormal hemoglobin, procurement of a blood sample in an acute emergency setting when venous sampling is not feasible, contraindications to performing an arterial blood gas, an abnormal modified Allen test, local infection or distorted anatomy at the puncture site, severe peripheral vascular disease, active Raynaud syndrome, repeated arterial needle sticks when the INR is greater than or equal to 3, and/or the activated partial thromboplastin time is greater than or equal to 100 seconds, a platelet count of less than 50. Choosing our site. Locate a palpable artery. Common sites include the radial, femoral, brachial, dorsalis pedis, or axillary arteries. There is no evidence that any site is superior to the others. The radial artery is used most often because it is accessible and more comfortable for the patient than the alternative sites. What is a modified Allen test? Modified Allen tests measure arterial competency. They should be performed before taking an arterial sample. To perform a modified Allen test, have the patient clench their fist several times while also applying occlusive pressure to both the ulnar and radial arteries. Have the patient then relax their hand and look for any blanching. If there's no blanching, you have not completely occluded the arteries with your fingers. Release the occlusive pressure on the ulnar artery. A positive sign is hand flushing within 5 to 15 seconds. This indicates a patent ulnar artery. A negative sign is a hand that does not flush within 5 to 15 seconds. This indicates inadequate circulation and is contraindication for an ABG. Challenges that may be experienced in performing an ABG. They are difficult to perform in uncooperative patients, when pulses cannot be easily identified, when patients cannot be positioned appropriately, in obese or edematous patients with large amounts of subcutaneous tissue which may obscure the usual anatomical landmarks. Ultrasound may be useful to locate the artery and reduce potential complications of repeated puncture and consequent injury to the target vessel and surrounding tissue. The equipment necessary should be brought to the bedside prior to the procedure. These include non-sterile gloves, antiseptic skin solution, an ABG kit or a pre-heparinized 3 ml ABG syringe with a 22 to 25 gauge needle and syringe cap, a 2x2 inch sterile gauze, adhesive bandage, plastic hazard bag with ice, sharp object container, lidocaine without epinephrine may be required should the clinician feel that anesthesia is necessary or the patient requests it. An ABG kit contains a heparinized plastic syringe with the plunger already pulled back to allow for the collection of 2 mL of blood, a protective needle sleeve, a needle, syringe cap, and an ice bag. In order to perform the procedure, you must first introduce yourself to the patient and explain what is going to happen. Locate a palpable artery. Radial artery is preferred. Thumb may not be used in palpation. If requested, use 1 to 2% lidocaine, administering 0.5 to 1 mL, creating a small dermal papule at the site. ABG kits are used by clinicians in most institutions to draw arterial blood. Alternatively, a heparinized syringe can be used. Prepare the puncture area with betadine and then with alcohol wipes, allowing the solution to dry before puncturing the skin. Palpate proximal to the planned puncture site with the index finger of the non-dominant hand. Adduct the patient's arm and dorsiflex the wrist approximately 30 degrees. Insert the needle at a 60-degree angle to the skin and advance to the artery with the bevel side up. The artery should be punctured with the needle at a 30 to 45-degree angle, or at a 90-degree angle relative to the skin. Assess for flashback of blood into the syringe, then allow the syringe to fill. The syringe should fill on its own. Pulling the plunger is usually unnecessary. Approximately 2 to 3 mL of blood should be removed. Next, place a 2x2 inch gauze pad over the puncture site and withdraw the syringe. Hold pressure over the puncture site for 5 minutes or until hemostasis is achieved. A needle safety device is engaged and appropriately discarded. Use caution to avoid needle stick injury. Cap the syringe, hold it in one hand, and rotate your wrist back and forth for 20 to 30 seconds to allow blood to mix with the heparin. In the patient's presence, label the specimen and place on ice in the hazard bag and send it for analysis. Check for a pulse downstream from the puncture site to ensure no thrombus has formed. Post-procedural care. Patients should be monitored for new symptoms, including skin color changes, persistent or worsening pain, active bleeding, impaired movement or sensation of the limb. Monitoring is particularly important in patients who are subsequently supratherapeutic on anticoagulants or are given thrombolytics, as bleeding may be observed in such patients even though the needle stick occurred a few hours prior. Common complications include local pain and paresthesia, bruising, local minor bleeding. Less common complications include vasovagal response, local hematoma, artery vasospasm. Serious complications include infection at the puncture site, arterial occlusion from a local hematoma, air or thrombus embolism, local anesthetic anaphylactic reaction, local nerve injury, needle stick injury to a healthcare personnel, or vessel laceration. These are the supplementary slides for the arterial blood gas presentation. This video is a physio-tutor's video demonstrating how to perform the Allen test, as well as how to interpret the findings. This is a link to a Geeky Medic's guide for performing an ABG blood draw. Acid-base analysis should be performed in the following order for ease of interpretation. 1. Look at the pH to assess acid versus base. 2. Look at the direction of pH and PCO2 to assess metabolic versus respiratory. 3. Look for compensation. 4. If metabolic acidosis, look for anion gap. 5. If metabolic alkalosis, look for urine chloride level. This flowchart is a visual demonstration of the order in which you analyze acid-base disorders. You may want to pause the video at this time to get a closer look at the flowchart. This flowchart provides a visual demonstration of mixed acid-base disturbances. You may want to pause the video at this time to get a closer look at the flowchart. This flowchart is a visual demonstration of how to analyze acid-base disturbances. Again, you may want to pause the video at this time to get a closer look at the flowchart. This slide provides a link to the WHO guidelines for blood draws. This is the end of the arterial blood gas presentation.